Bismillah ar-Rahman ar-Rahim. This is Professor Abdussalam Yassin Taha from the College of Medicine, University of Sulaimani, giving a talk on pulmonary bullet embolism, the story of a bullet that traversed the heart twice. Background: most high-velocity bullets enter and leave the body in a straight trajectory, while the low-velocity bullets may penetrate vessels, cardiac walls, or bowel and behave as bullet emboli. Bullet embolism is a rare phenomenon in trauma, with only 300 cases published before the year 2011. Bullet embolism to the pulmonary artery was first reported by Morstan in 1903. Migration of bullets into the pulmonary artery is described most often with lesions of peripheral veins without concomitant cardiac involvement. Gunshot wounds of the heart with migration of the bullet into the pulmonary artery are rare. Herein, we present a very rare case of bullet embolism from the right atrium to right internal iliac vein and back to right heart and left pulmonary artery, in which the patient survived trans-thoracic extraction of the bullet from left lower pulmonary lobar artery. Case presentation: on March 4, 2019, a man of 39 received a low-velocity bullet injury. It was an accidental bullet falling from height. After a CT scan of the chest revealing a bullet in the right atrium and a moderate right-sided hemothorax, the patient was referred next day to our teaching hospital for further care. Luckily, the patient on arrival to our hospital was clinically stable, apart from mild shortness of breath and slight hypotension. There was a 4 cm non-bleeding wound located in the right 6 intercostal space, 7 cm lateral to the spine. Air entry on right lower back was reduced. Heart sounds were muffled, abdomen was soft on palpation, and peripheral pulses were palpable. His vital signs were a blood pressure of 95/55 mm mercury, pulse rate of 110 beats per minute, and oxygen saturation of 91% that increased to 96% with oxygen supplementation via a mask. Unfortunately, neither the CT scan films nor reports were brought with him. Therefore, a chest X-ray was ordered. The hemothorax was evident, but no bullet was seen in the region of the chest. A chest tube was placed and drained 400 cc of blood. To our surprise, the bullet had descended to the right pelvis as shown by a plain pelvic film. When the initial CT scan of the chest was reviewed later, the bullet was seen in the right atrium along with mild pericardial effusion, and hence a migrating bullet was our provisional diagnosis. Doppler ultrasonography revealed normal abdominal vessels and failed to locate the bullet. CT angiography was arranged and showed the bullet outside the arterial tree but adjacent to iliac arteries, most likely inside the right internal iliac vein. Meanwhile, the chest drainage ceased and chest tube was removed after 5 days. So here, a right-sided hemothorax was revealed by plain X-ray of the chest and drained by closed tube thoracostomy. And the next day, the pelvic X-ray revealed the bullet in the right pelvis. CT scan on the day of trauma showed a bullet in the right atrium with moderate right-sided hemothorax. And CT angiography showed the bullet adjacent to the iliac artery, mostly in the right internal iliac vein. Although our patient had no evidence of arterial or venous occlusion, we advised him for surgical exploration to extract the bullet and save him from potential complications of a bullet migrating in the major abdominal veins. Unfortunately, the patient refused surgery and left the hospital despite our warnings. The dramatic change occurred 3 months later when the patient was readmitted due to sudden onset of shortness of breath, chest pain, and sweating, which gradually worsened. On examination, he had a rapid pulse but normal blood pressure. CT scan of the chest revealed a new surprise. The bullet was seen in left pulmonary artery. So that was the CT scan of the chest pulmonary window showing the bullet in the left lower pulmonary lobe. An urgent left thoracotomy was done and 0.36-inch caliber bullet was extracted from a basal branch of left pulmonary artery. The patient had an uneventful recovery and left the hospital 4 days after surgery. He was in a stable condition when seen 2 months later. So that was a left thoracotomy photograph showing the removal of the bullet from the left lower lobe and the path of the bullet migration is displayed in this figure. So this is the path of the bullet. It entered from the right back to the right atrium, down to the IVC, down to the right internal iliac vein, and then back through the IVC to the right atrium and right ventricle, and then to the pulmonary artery to settle in a basal branch of the left pulmonary artery. Discussion. In our country and many other countries with insufficient security, many people possess firearm weapons and may use them illegally, contributing to an increase in civilian violence. One common situation is shooting during social and national celebrations, the so-called celebratory gunfire, in which innocent persons may become injured or even killed. The case described herein was hit by a stray bullet falling from a height, and therefore most likely it was of low velocity. Bullets fired into the air usually fall back with terminal velocities much lower than their muzzle velocity when they leave the barrel of a firearm. The reported cases of pulmonary bullet embolism have mostly followed lesions of peripheral veins without concomitant cardiac involvement. Cardiac gunshot wounds subsequently complicated by migration of bullets into the pulmonary arteries are reportedly rare. Following trans-thoracic gunshot wound, the bullet in the index case penetrated the right atrium and made two migrations thereafter. First, it moved through the inferior vena cava down to the right internal iliac vein. Such retrograde venous bullet migration is expected in the very large veins, particularly in standing position and during cuffing or a Valsalva maneuver. Second, it returned back into the right heart to settle in the left lower pulmonary lobe artery. Such projectile pathway is very interesting and rare. We didn't come through a similar case in the literature. Our case had the typical criteria of small-sized, low-velocity bullet with inlet but no exit wounds and locations in body regions far from bullet trajectory. Due to symptoms and signs of pulmonary embolism, bullet extraction was indicated and was successfully accomplished by open surgery, as our hospital lacked endovascular facilities. Two scenarios were involved in this case of pulmonary bullet embolism: a cardiac gunshot wound and migration of a bullet through a peripheral vein. Owing to their extreme rarity, no physician and no center had sufficient experience in management of intravascular migrating bullets. However, high clinical index, along ancillary radiographic and imaging techniques, may enable the physician in charge to make a timely diagnosis and initiate proper therapy. Our patient was saved by surgical extraction of the bullet via left thoracotomy. However, one wonders what happened to the entrance wound of the bullet into the right atrium. Most likely, this wound had sealed spontaneously after an initial bleed which produced the right hemothorax. The bullet could have caused an incomplete obstruction of the IVC or the iliac veins. That's why there was no clinical evidence of venous occlusion. Conclusions. We believe that radiographic confirmation of the location of an intravascular bullet is mandatory just prior to surgery, as the bullet may suddenly change its location. The intraoperative use of fluoroscopy is also very helpful in such cases. Even without a Doppler ultrasonography, echo, and/or CT exam, if the plain radiographs show a change in position of the bullet quickly from one body region to another, this should alert the physician to the possibility of intravascular bullet location. Well, this presentation is based on a publication. I have published this case report in the Cardiothoracic Surgeon Journal at 2020, and was co-authored by my colleagues Dr. Dilan Ahmed Baqir and Dr. Yad Uthman.